we started
Sorry,
we
go ahead.
started these sessions we started these sessions जहाँ चाहिँ अब कसैले के आउँछ भने उसले आएर प्रेजेन्ट गर्न सक्छ and surprisingly we got a very good response अनि कम्युनिटीमा पनि more than 1000 members from different countries अझ नेपालीहरू different countries मा पढिरहेको MBBS उहाँहरू जोइन हुनुभएको थियो अनि we had a very good experience of exploring what happens in other medical colleges त्यो पिरियडमा चाहिँ अहिले चाहिँ I'm very thankful to both of you for initiating this thing अनि सुवर्ण दाइलाई चाहिँ यो सेसनहरू फेरि पनि सुन्न पाइयोस् न एउटा सेसन मात्रै होइन पछि पनि लाइक मन्थली सेसन हजुरले भने जस्तै वी आर एक्सपेक्टिङ द्याट पनि अनि त्यसले अडियन्स पनि सायद बढ्दै जाला जस्तो लाग्छ मलाई यदि रेगुलरली हामी गऱ्यौँ भने सो थ्याङ्क यू त्यति नै भन्नु छ
Thank you so much. Your session ko लागि चाहिँ will be trying to make it a very interactive session and सबैजनाको मोबाइल फोन छँदैछ होला अथवा चाहिँ कम्प्युटर अथवा जुनै पनि इलेक्ट्रोनिक डिभाइसमा कि त एप डाउनलोड गरौँ KAHOOT Kahoot भन्ने एप अथवा चाहिँ kahoot.it मैले भर्खर च्याटमा पनि पोस्ट गरेँ ब्राउजरमा गएर kahoot.it भनेर खोलेर ओपन राखौँ अनि त्यसपछि विल बी रनिङ सम सेसन्स अन द्याट kahoot.it KAHOOT Kahoot.it So let's move forward.
It asks for a pin. Do we have a pin?
Yes. Yeah, we'll be providing the pin. Let's hold on for a session. So this is going to be the Kahoot. Our entire session is Kahoot based. So we'll start it and I will have a pin for you. Just a second. Are you guys able to see my screen right now? Excellent launch on this, huh? Your screen ma PowerPoint देखिरहेको छ कि यो Kahoot देखिरहेको छ 1534872 Kahoot को पिन देखिरहेछ यो Kahoot देखिरहेछ अहिले स्क्रिनमा छैन
So are they 158
and 153 your right it's nine
chat मा लेख्दिम न
mine this screen नै त्यही देखाइदिन्छ अनि 1534872 excuse me सबैजनाले Kahoot जोइन गर्नु है kahoot.it मा गएर ब्राउजरमा अनि यो 1534872 पिन रहेर I'll wait for like 30 more seconds. Okay, so we have, okay, people are still joining now. Kahoot.it, for those of you who just joined, KAHOOT, Kahoot.it, you can also scan the QR code. Kahoot.it ma gaera athwa Kahoot app ma gaera 1534872 pin हाल्ने. And I'll keep moving forward. You pin display पनि भइरहन्छ पछि. Okay. Let's go ahead. Excuse me. So this is our session today, approach to acute abdomen. We'll have a first question now. Which of the following is false regarding airway breathing and circulation in acute abdominal pain? Overbagging for airway support increases risk of vomiting or aspiration. One small bore IV access is usually enough. Supine or recumbent position increase risk of aspiration, or administer broad spectrum IV antibiotics. This is kind of a difficult question, but it says which of the following is false? So rest of them must be true. Only one of them is false. Sorry, it was sort of a difficult question in the beginning itself. The rest of our questions will be a little easier. Which of the following is false regarding airway breathing circulation in a patient presenting with severe acute abdominal pain? So over bagging, like let's say if we're trying to intubate, if we're before bag. Ramesh Pai, so for when we're trying to intubate a person who is sick because of some abdominal pathology, we always have to ventilate them before intubation with like a bag and mask support. And if we bag too much, they're going to have so much air in their abdomen or stomach that there is increases in aspiration or vomiting. This is sort of a difficult concept, but sorry that this is the first question. And we usually like to say anyone who is sick needs to wide bore IV access, let's say at least 18 gauge or 16 gauge if possible. And supine position does increase the risk of aspiration, so that is not false, that is true. And we do administer broad spectrum IV antibiotics if the patient is septic. The second option was false. Let's move forward. We'll have some other better questions. And let's see. It's good that at least two of you were still able to answer that question. Okay, so we will have an ultrasound image on the screen, and let's try to see what we find. This is also a little bit relatively difficult, but if you can see the screen, this is the right upper quadrant, and this is the kidney, and this is the liver, and there's some finding in here. So maybe you can think about what this could be. And down below here is the diaphragm. Great, we got 4 correct answers. Yes, that was free fluid in Morrison's pouch. Don't worry if you didn't understand what is going on there. We'll have a look in the next slide. So what we see here is a view of the right upper quadrant. And in the right upper quadrant, down below on the bottom, the part that you see white is part. It's called hyperechoic, and that is the diaphragm. And just next to the diaphragm here is the kidney. We see the kidney in its longitudinal view, sort of like a longitudinal cross section. And this black structure, which we call hypoechoic in ultrasound terminology, is free fluid in the right upper quadrant. And then next to that, sort of isoechoic structure, or like a gray structure, is the liver. So when we see black structure here, that is free fluid. And when we're doing EFAST or ultrasound of the abdomen when a person presents with hypotension, this is what we're looking for. This is a positive finding. Anyone have any questions about that? So I have a slide to demonstrate what I was just talking about. So high up here, just next to the diaphragm, is the lung, and then hyperechoic, like white structure called the diaphragm, and then the liver, and down below here is the kidney, and there shouldn't be any fluid here. This is the Morrison's pouch, and if we see any black structure or a hypoechoic structure here, that is free fluid. Okay, let's go for another one. So this is hopefully an easier one. Providing pain control can affect diagnosis of the cause of acute abdomen. So there is this concept where we don't want to give pain control, and we just want to wait. Okay. Yes, everyone answered correctly. Pain control should be provided. It is there is this false concept that if you provide pain control, pain control we'll lose the classical signs of abdomen. For example, Murphy's sign, right upper quadrant, tenderness, appendicitis signs or in classic signs or pain management, strong pain medication, strong pain control concept, concept. And I'm just trying to show you guys that is false. We have to give pain control to anyone who presents to the emergency department, appropriate for their level of pain. Any questions so far? I can stop. And if I can monitor the Zoom chat. Okay, I'll proceed. Next question. So there are some important causes of abdominal pain when patients present with abdominal pain to the emergency department. The first one is that we cannot, there are some causes that we cannot miss. Abdominal pain later on that is ER, but there can be several causes of abdominal pain. And we are usually not able to find out, a lot of times we're not able to find out what caused their severe abdominal pain. We treat their pain, we do some investigations, and they get better, and then usually they go home. Many of them get admitted because they are having a serious surgical or medical emergency. But these are the 5 or 6 causes that we should always think about on the top of our mind. When people present to the ER with any condition, we want to make sure that they're not presenting with some serious conditions rather than to try to find out what exactly caused abdominal pain. So aortic dissection or abdominal aortic aneurysm, these are the 2 very life-threatening conditions, and people can die very fast when they have this condition. So we have to keep this as a differential on our on the back of our mind. And these are rare conditions, luckily, but this can just lead to death. So we have to keep that in mind. And the next one is mesenteric ischemia and intestinal obstruction, and perforated viscous, as in perforated gastric ulcer or perforated duodenal ulcer, or even ectopic pregnancy. Okay, let's go to the next slide. Sorry. We have a 65-year-old diabetic female presenting with severe acute abdominal pain, diffuse tenderness to palpation. So which of the following would you do? Would you get an ECG on this person? Would you order venous blood gas or blood gas? And would you get a CT abdomen, or would you get all of the above? It's okay to just answer whatever you think is correct. Great. Yes. Yeah, most of you give the correct answer. Yes, this is a 65-year-old female with diabetes. So there's a lot of information in that question. Anyone who is over 65-year-old and presenting with severe abdominal pain in the ER, there is a very high likelihood that they are presenting with something life-threatening. And because of that, in such cases, depending on their exam, we say here that it's diffusely tender to palpation. If it's not tender at all, that's fine. But if it is tender, if the pain is severe and they have risk factors like age and diabetes, then we have to order a CT scan. Anyone over 65-year-old, you have to have a really low threshold for getting a CT scan of the abdomen, because it is very likely that this person has a bad condition that led to the abdominal pain. And female, diabetic, elderly, if they present, especially with epigastric abdominal pain, it can be because of something related to the heart. It can be usually because it can be, there's a good chance that it can be because of acute coronary syndrome or a myocardial infarction. And that is why you have to start with an ECG. And if it is an ongoing pain, maybe you also have to get a troponin. And I said she's diabetic. So if patients present with acute abdominal pain and they are diabetic, we have to have diabetic ketoacidosis on our differential. And that is why we'll get a blood gas. It can be arterial or venous blood gas. And that is where we start. because we want to make sure they don't have diabetic ketoacidosis. Panda, good job so far. Okay, so there is a 17-year-old female presenting with right lower quadrant pain, and you are thinking appendicitis. You ordered a UA or urinalysis, and that shows abundant leukocytes. So do you think we can stop workup for appendicitis? Maybe the UA is positive, so that means they don't have appendicitis. Great. Yeah. So when there is a positive UA, we are like, other people, we usually think about, oh, they probably have a urinary tract infection. So maybe we should get a urine culture and treat them with antibiotics. But in a patient who is at a high risk for appendicitis, let's say like a 17-year-old female and presenting with right lower quadrant pain, and maybe also tenderness to right lower quadrant, even though they have leukocytes in the UA, we have to know what can cause that. So for sure, if they have a urinary tract infection, there can be leukocytes. But then there is this another pathophysiology, because if there is an inflamed appendix, it can irritate the ureter, and the ureter can also have some inflammation secondary to the appendicitis, and we can see leukocytes in the urine. So it doesn't have to be from a UTI; it can still be appendicitis. Therefore, we have to be very careful when we are examining patients like this. And appendicitis is one of the fairly common causes of acute abdomen, so we have to keep that as a differential. And even with a UA that shows suggestive of infection, we have to be very careful about dismissing the differential of appendicitis. Panda is still leading, Susman is second. Okay, so let's talk about some blood tests that you might order, or some workups that you might order. So whenever a patient presents with severe abdominal pain, you can ask the nurse, or you can yourself get a random blood glucose, a point of care glucose, or a finger stick glucose with a glucometer. And usually, if they have DKA, if they are at risk for DKA, because like a lot of times this can be their first presentation, they don't know they have diabetes, and they present in a diabetic ketoacidosis. So if they do have diabetic ketoacidosis, their blood sugar is going to be really high, usually higher than 300s, and then we can keep diabetic ketoacidosis in our differential. But if the blood sugar is normal, then we can keep that out of the differential, and we can worry about other things. And we have to get a pregnancy test in any female. I know that you've heard this several times. Any female presenting with abdominal pain in the ER, if they are in the reproductive age group, we have to get a pregnancy test, because they are at a risk for ectopic pregnancy. And do not trust. It's a good thing to trust people, but usually the history can be misleading. So just always get a pregnancy test. And WBC counts are not a very reliable test. So if, let's say, if someone had an intra-abdominal abscess and the white cell count is normal, you are inclined to think, oh, they probably don't have an infection because the white cell count is normal. Don't do that. Don't trust WBC count. It can be normal. It can. It is not a sensitive test. We get packed cell volume or hematocrit. That is the more reliable test than just a hemoglobin level, but it can be low in a patient with severe bleed, but sometimes it can be normal because the body has compensated, or the body has not had the time to come. It is acute bleeding, then it can be normal. So don't rely on just that if you have a high risk for, if you have a high suspicion for some kind of hemorrhage going on. And lactate or venous blood gas is useful. Like I said, venous blood gas is useful for diabetic ketoacidosis. But something to remember is that people who have mesenteric ischemia, which is also very risky condition for abdominal pain, can have elevated lactate. And we know lipase is for acute pancreatitis. urinalysis that we just talked about can be misleading. Hematuria can be caused by kidney stones, but it can also be caused by abdominal aortic aneurysm ruptures. So we have to keep that in mind. And anyone who looks pale, who looks toxic, we have to order type in a screen test or type in cross match as soon as they arrive, because these people may have some internal hemorrhage. Okay, we're going to the next question. So we call it rapid ultrasound in shock. Just read the options. Rapid ultrasound RUSS Ross exam. We just talked about like some difficult causes or very risky causes of abdominal pain. So if they present with hypotension, which of the following would you look for in the ultrasound? So this may be a new concept. It's okay not to know the answers, but let's just give it a try. Yes, so I kept all of these options as correct because, yeah, we're looking for all of this when we're doing a rapid ultrasound. So it is a bedside ultrasound. It can be done by anyone who has had a point of care ultrasound training. And we're going to look at the heart because with 4-chamber and parasomnia view. So we're looking at the heart for anyone who is presenting with hypertension because they can be in cardiogenic shock. We're going to see if the heart is beating fine, or there may be some other findings, let's say like a pericardial effusion, and that is causing pericardial tamponade, and that's why this person is hypotensive. We're looking at the IVC. So there's this idea where if you look, if you examine the inferior vena cava with the ultrasound, we look at the diameter and the changes in diameter, so we can sort of predict if this patient has hypovolemia versus hypervolemia when we examine the inferior vena cava with ultrasound. And either of that can cause hypotension. And we just talked about Morrison's pouch or the right upper quadrant where we can see some free fluids. And we talked about abdominal aortic aneurysm. I kept saying it is a high risk condition. So there is a way to look at the aorta with the ultrasound, and it is fairly good, fairly accurate to sort of even rule out abdominal aortic aneurysm in a person presenting with abdominal pain. And if they are hypotensive, we know that tension pneumothorax can cause hypotension. So there's a way to look at the lungs with the ultrasound to see if there's any pneumothorax in them, and all of these are correct. And still leading, good job. Okay, this is a poll, so you can just select and any of these answers will be correct. Which of the following antiemetics do you use the most, or have you used before, or are you familiar with the most, or you can, or whatever you feel comfortable using? So ondansetron, ondem, we have heard of that medicine. Metoclopramide, promethazine or phenergan is the same thing. And then we have this oral antiemetic called domperidone, and we have prochlorperazine. So whichever one have you used before? And we'll talk about them in a little bit. Great, yeah. So ondansetron is the most popular one, and there's a reason for that. But yeah, can we talk about ondansetron? Can anyone tell me what they know about ondansetron, or just maybe type in the chat? How does it work? This is a
so am I audible?
yes.
Hello. So basically, सुनिराख्नु भएको छ नि है मेरोमा माइक्रोफोन चलेको छैन जस्तो लाग्यो कि त्यही भएर सो बेसिकली ondansetron चाहिँ serotonin receptor blocker हो and it really acts on serotonin receptor in GI tract and in the brain, specifically 5-HT3 receptor, and like metoclopramide are the prokinetic drug. They the gastric emptying, they fasten, they quicken the gastric emptying process. So more commonly चाहिँ लगभग ondanहरू नै युज भइरहेको छ इमर्जेन्सी सेटिङहरुमा पनि. So I think it's fairly more
राइट अनि त्यसको अब कारण पनि छ किन भन्दाखेरि ओनानसेट्रोन भनेको एकदम सेफ पनि हुन्छ त्यसको साइड इफेक्ट्सहरु एकदम थोरै पनि छ हैन अब हो ओनानसेट्रोन सेरोटोनिन रिसेप्टर ब्लकर हो अब मेटोक्लोप्रोमाइड चाहिँ डोपामिन रिसेप्टर एन्टागोनिस्ट हो डोमपेरिडोन पनि सिमिलर मेकानिजम हो क्रोमेथाजिन चाहिँ अब एन्टाकोलिनर्जिक अथवा एन्टाहिस्टामिनिक हो अनि प्रोक्लोरपेराजिन भनेको एन्टासाइकोटिक हो तर यसको अब एन्टाइ हिस्टामिनिक एन्टाकोलिनर्जिक प्रपर्टिज हुन्छ त्यसले गर्दाखेरि एन्टाइमेटिक हुन्छ यो सबै मध्ये सबभन्दा सेफ चाहिँ ओनानसेट्रोन हो दुई तीनवटा कारणले गर्दाखेरि एउटा मेटोक्लोप्रोमाइड र डोमपेरिडोन चाहिँ डोपामिन रिसेप्टरमा काम गर्ने भएको भएर तिनीहरूको के साइड इफेक्ट हुन्छ हामीलाई थाहा छ metoclopramide most common side effect. Yes, extrapyramidal symptoms, EPS अथवा extrapyramidal symptoms को पनि धेरैवटा manifestation हुन्छ एउटा dystonia हुन सक्छ and that is the most common one. अब अरु चाहिँ पछि akathisia अथवा चाहिँ tardive dyskinesia भनेको चाहिँ akathisia चाहिँ common हो तर tardive dyskinesia भनेको चाहिँ late side effect हो. So most common भनेको dystonia भनेको usually patientहरुलाई metoclopramide दिदा दिदै involuntary muscle contraction हुन सक्छ. For example, torticollis हुन सक्छ उले अब आफूले थाहा पाइरहेछ के भइरहेको छ तर they can get torticollis अनि it's fairly common as well. त्यो भयो भने ट्रिटमेन्ट के हुन्छ थाहा छ त्यो मेटोक्लोप्रामाइड कसैलाई दियो अनि दिदा दिदै भनौँ एक्स्ट्रापिरामिडल सिम्पटम्स देखियो भने इआरमा के गर्छ एक्सक्युज मी सो अब त्यसको ट्रिटमेन्ट भनेको चाहिँ जस्तो पार्किन्सोनिजमको मेकानिजम सम्झ्यो भने थाहा हुन्छ तर त्यसको ट्रिटमेन्ट भनेको एन्टाइकोलिनर्जिक सो वान अफ दिस ड्रग्स वी क्यान गिभ देम प्रोमेथाजिन एन्ड दे विल बी फाइन एन्टाइकोलिनर्जिक अथवा एन्टाहिस्टामिनिक्स एडमिनिस्टर गर्ने यदि हाम्रो अगाडि हामीले भर्खर कसैलाई मेटोक्लोप्रामाइड आइभी दियौँ र डिस्टोनिक रियाक्सन भयो भने चाहिँ अथवा अर्को चाहिँ एकाथिजिया भने पिपल गेट एङ्सियस एजिटेटेड अनि ट्रेमर्सहरू जस्तो देखिन थाल्ने हुन सक्छ त्यस्तो भयो भने चाहिँ वी क्यान गिभ देम एन्टाहिस्टामिनिक्स बट अर्को पनि साइड इफेक्ट चाहिँ यसले चाहिँ क्युटी प्रोलङ्गेसन गराउँछ र वी डोन्ट नो फर द मोस्ट पार्ट मान्छेले के मेडिकेसन खाइरहेको छन् घरमा अब दुईटा क्युटी प्रोलङ मेडिकेसन भयो भने दे क्यान it can be bad for them. त्यही भएर पनि अब unknown अथवा undifferentiated पेशेन्टमा although it is not very dangerous तर यो भन्दा चाहिँ ओनानसेट्रोन सेफ हुन्छ यो अब डोमपेरिडोनले पनि गराउन सक्ने भयो प्रोक्लोरपेराजिनले क्युटी प्रोलङ्गेसन गराउन सक्छ रिलेटिभली नट सो कमन तर यो सबै भन्दा सेफ चाहिँ ओनानसेट्रोन हो त्यही भएर वी लाइक ओनानसेट्रोन एन्ड इट्स भेरी कमनली युज्ड ड्रग अब अर्को यस्तै क्वेसन इज हो फेरि यो पनि पोल 46-year-old male presenting with acute abdominal pain what would you give it all of these answers are like most of these answers are correct let's not say all of this but what would you give for abdominal pain Yes, the only thing I would be hesitant to give to this person is ibuprofen. Can someone tell me why? Kina ibuprofen dinalai चाहिँ अलिकति risky हुन सक्छ? So for all we know,
AI stress of acute abdominal pain or shock अरुहरु यदि हार्टको aortic aneurysm हरुको केही कजहरु छ भने like it can cause AKI blood.
Yes, yes, a non-steroidal anti-inflammatory drug or any of the non-steroidal anti-inflammatory drugs have sort of like similar side effects. And you're right, it's saying kidney function affect. So you by a 56-year-old male presenting with acute abdominal pain, we don't have any other information. We don't know what their kidney function is. So surumai ibuprofen, someone posted in the chat, they said if peptic ulcer disease is present. So who knows if this person has peptic ulcer perforation or peptic ulcer just leading to abdominal pain, and we're going to make that worse by giving ibuprofen because we know NSAIDs are one of the common causes for acute gastritis or chronic gastritis or bleeding. So non-steroidal anti-inflammatory drugs do cause some platelet dysfunction, although सबभन्दा धेरै इफेक्ट चाहिँ एस्पिरिनको हुन्छ तर कुनै पनि any drug from this group can cause bleeding disorder, and if this person has let's say for example a peptic ulcer disease which is bleeding and that is why they have this pain, we're going to make it worse. So the idea from this slide is, yes, we have to treat this pain. We can use any drugs. Let's say morphine is fine, undifferentiated abdominal pain, but there was the classic teaching, maybe KD3 party still like some morphine because it causes spasm of sphincters or whatever. But that is an old concept that has never been shown to be true in research. And we use morphine for undifferentiated abdominal pain all the time, and nothing ever happens, like nothing ever goes wrong. So morphine available on ER, we can use morphine. Moderate size commands, we can start with 4 milligrams IV, and then if they're bigger, we can give 8 milligrams IV, or suruma 4 दिएर control भएन भने त्यसपछि अर्को 4 दिन सकिन्छ। तर usually नेपालमा हाम्रो patient population लाई चाहिँ morphine दियो भने त उनीहरुको pain fairly well control हुन्छ। अथवा मोर्फिन अलिकति लङ्गर ड्युरेसनसम्म काम गर्छ जस्तो लाग्यो र कोही बेला चाहिँ मोर्फिनले अब अलिअलि एन्टाकोलिनर्जिक साइड इफेक्ट्सहरू हुन्छ, अलिअलि फ्लसिङ हुन्छ, अलिअलि नजिया हुन्छ, त्यस्तो जस्तो लाग्यो भने चाहिँ वी क्यान गिभ फेन्टनिल। बट द थिङ इज फेन्टनिल इज भेरी सर्ट एक्टिङ, तत्कालको लागि चाहिँ यसले पेन कन्ट्रोल गर्ने भयो, तर इट्स भेरी सेफ टु गिभ। हामीलाई अब क्लासिक टिचिङमा चाहिँ मोर्फिन युज भन्दा फेन्टनिल डेन्जरस, फेन्टनिल चाहिँ ओआरमा मात्र युज गर्ने, आइसीमा मात्र युज गर्ने भनेर सिकाएको छ, तर द्याट इज नट ट्रु। वी युज फेन्टनिल इन आवर इमर्जेन्सी डिपार्टमेन्ट्स all the time, and it's totally fine. It's a very good drug. The good thing is effects is short duration going back over if there is like lower risk of the patient having hypotension for a prolonged period, because we know morphine can cause hypotension. Fentanyl can also cause hypotension, but it's going to be short lasting. Or we have a very good drug, paracetamol or acetaminophen, and a lot of times it's got IV formulation available. So IV formulation is usually 1 gram. So we can start here with for pain control for a lot of patients. And if we give 1 gram of paracetamol, it is severe pain sign, it can help a lot. And especially with IV formulation, it can help a lot. So only thing I would stay away from in a person with unknown cause for abdominal pain here in these options is ibuprofen. One more poll. So which antibiotics? So we talked about antiemetics, we talked about pain control. Which one is your going to be your antibiotic of choice? Let's say they have severe sepsis, hypotensive, fever, abdominal pain. And this is just a poll, mind, please keep that in mind. It's not a quiz question. Okay, so looks like most people would prefer cefepime and metronidazole. All of these options are correct, by the way, and it's okay to start with cefepime and metronidazole because maybe most of us are most familiar with that, and that is because cefepime is a broad spectrum antibiotic. It covers most of the gram-positive and gram-negative bacteria, and we add metronidazole to that in order to cover anaerobes. And broad spectrum coverage boy. It is your slide go idea. It is important to remember that, and there's a lot of anaerobes causing infections in the abdomen, and whatever antibiotic we give empirically should have anaerobic coverage. Metronidazole add cefepime. Metronidazole is a good combination. Or second option could be piperacillin, tazobactam. Isma advantage we're also covering for Pseudomonas, and this is a good antibiotic option. Isma anaerobic coverage pani huncha, Pseudomonal coverage pani bhayo. Ampicillin, sulbactam, also very broad spectrum, also has some anaerobic coverage, and this is a good choice as well. And we have meropenem. So meropenem is very broad spectrum, sort of like a backup antibiotic. But if someone is really sick and we think they're going to go to the ICU, it's okay to start them on meropenem. And but it's also very expensive. So all of these are good options, and I like that you guys chose cefepime and metronidazole for the most part. Okay, so some things to remember about abdominal pain, just some points. We have to remember, we know a person who has, let's say, for example, cholecystitis will usually present with right upper quadrant pain. There will be tender to palpation to the right upper quadrant. And we have been taught, okay, it's probably going to be a middle-aged female, and it's more likely if they are like obese or heavy. And then let's say like a young person presents with right lower quadrant pain, tender to palpation, psoas sign is positive, McBurney sign is positive, we think it's going to be acute appendicitis. If there's for someone from any age presenting with flank pain or like renal angle pain that radiates from loin to groin, and it's intermittent colicky pain, they're vomiting, and we are thinking of kidney stones. So these are like classical findings, and it is important to remember these classical findings are not always common. And it is important to remember also that immunocompromised patients and elderly patients may not have any of these classical findings at all. And they will present with just vague abdominal pain, just vague symptoms, nausea, vomiting, maybe diarrhea. And we have to keep them in the hospital. We have to watch them. We have to observe and serially do exams. And also, like we said, we should have a very low threshold for getting a CT scan in a person who has some risk factors. Let's say, for example, if they had an abdominal surgery in the past. Can someone tell me, sorry, abdominal surgery, what is the high differential for abdominal pain in a person with abdominal surgeries in the past? Let's say there, yes, Prarthana, good job. So, abdominal surgery box usually with recent surgeries. So let's say if they had a surgery and they present to you later with abdominal pain, and let's say distension of the abdomen, and they're not able to pass stool, not able to pass flatus, just vomiting. You have to think about intestinal obstruction. And in patients like that, you have to have a low threshold for getting a CT scan, yes, and it is usually due to adhesion secondary to the surgery, or also, and that can lead to obstructions. And also remember that, let's say, for example, someone had appendicitis that became an appendiceal abscess, or it ruptured, and that led to peritonitis earlier. So someone who had perforated viscous earlier is at a subsequent risk for adhesions, and that can cause obstructions. So some more useful points in this slide. It says upright chest X-ray is more sensitive than abdominal X-rays for free air. So what we're looking for when we're talking about free air in the abdomen, what causes free air? Free air, let's just take chest X-ray, free air under diaphragm. Yeah, gas under diaphragm, or free air under diaphragm, is due to perforated viscous, usually duodenal ulcer perforation, so it can be due to intestinal perforation. So we have to see that. So this is an important point. Chest X-ray, chest X-ray, we are able to see, but it is more sensitive than abdominal X-rays for free air. So abdominal X-rays, abdomen standing upright, and lateral, and laying flat, classical. So we don't really do that anymore. If we think that people need abdominal X-rays, we have to get a CT scan probably. And because abdominal X-rays are low yield for obstruction, I mean, it's maybe a good place to start, but it doesn't have, it has very low sensitivity and specificity. We cannot rule in anything with that, and we cannot rule out anything with that. So therefore, the final conclusion is CT of the abdomen with IV contrast is the study of choice. And if we think there is mesenteric ischemia, then CT angiogram is the study of choice. Gas-forming organism, yes, it can cause air, holoviscous perforation, all of that is good. Thank you. Okay, so I have a question. Mesenteric ischemia, clinically, suspect got mesenteric ischemia. Can anyone tell me? Mesenteric ischemia presentation, you can also type in the chat, that's fine. Mesenteric ischemia, yes, pain after food, great. Exam. So these people have severe pain, but yes, they will have diffuse tenderness, but the pain is disproportionate to your exam. Pain is severe one, so the exam they're not they're not diffusely tender. Cecil, can you verify that?
Yes, Suvarna. So these people usually complain of like severe out of proportion pain, as you said. But on the examination, there may not be any findings. Like it can be completely benign. But people will be jumping out of bed because like they are in so much pain. So that's like completely disproportionate,
Yes.
basically. Yeah, that's
Yes.
right. Yeah.
The symptoms are more severe than exam findings. Thank you, Cecile. So when you're examining the patient though, because they have so much pain, you would expect them to be tender throughout. You'd expect to see some peritoneal signs, and you don't see those, but they have severe pain. And again, one of the labs that could suggest it is if you get a lactic acid level, it can be really high, and then you have to suspect mesenteric ischemia. And you may not be able to see it with just a CT with IV contrast, so you may have to order a CT angiogram if you suspect mesenteric ischemia. Okay, so final treatment. So why do we worry about abdominal pain so much, or acute abdomen so much? Because many of them require surgical interventions or interventions by specialists. And let's say we talked about abdominal aortic aneurysm and aortic dissection. So if that is going on, then we have to call vascular surgery, because they will be the ones to address that. We have to call them earlier rather than later. And mesenteric ischemia can be treated by general surgery, vascular surgery, or interventional radiology if that is available. Intestinal obstruction, of course, general surgery has to go and take care of the bowel that is necrotic and also release the aerations. And perfect viscous, general surgery is going to do their classical surgeries in that. And if it is an ectopic pregnancy, we have to call obstetrics and gynecology to address that. Yes, like Cecil said, it is like angina for bowel, and if you make your bowel work, like someone said, if you eat food, the bowels are going to have to work, and the blood supply is reduced. That's what mesenteric ischemia is, because the blood supply to the bowels is reduced, and if we increase their demand, or if you increase the work by eating food, the bowels are gonna feel the ischemia, and then that's when they're gonna feel the bowel angina or the pain secondary to the ischemia. So we just have a couple of questions. So it's a 35-year-old female presents with severe abdominal pain, controlled with medications. So you want to discharge this patient. We have some time to think about it. What is not a requirement to discharge them? So rest of the options are required, but one of them is not required. Let's think about the other way. What is required for them to go home? Excuse relatively young person presenting with abdominal pain, which is controlled after medication. So what other things you want to do before you can send them home? And this is from the ER, right? Of your admission पछि हैन? Oh, yes. The correct answer is CT scan performed and is normal, because that is not required. Right? This is a double negative question. So young person, when 65 years old, when the mathematical boy, when you're usually getting a CT scan if they present with severe abdominal pain, but this is a young person and their abdominal pain is now controlled with medication. And what I didn't put in there was exam findings not consistent with peritonitis. So we don't have physical exam findings suggestive of peritonitis. So then you can, oh, I apologize. So if they don't have peritoneal signs on exam, if their vitals are stable, and their pain is controlled with medications, what at the end of the day, हामी सबैजनाको पेनको कज चाहिँ पत्ता लगाउन सक्दैनौँ है अनि हामी के भन्छौँ तपाईको पेन चाहिँ मेडिकेसनले कन्ट्रोल भयो भाइटल साइन्स स्टेबल छ के एक्जाम फाइन्डिङ्स पनि रियसुरिङ छ मैले हरेकचोटि एक्जाम गर्दाखेरि पेरिटोनियल एक्जाम फाइन्डिङ्स भेटिन अथवा चाहिँ हाई रिस्क एक्जाम फाइन्डिङ्स भेटिन and then you ask them to drink a little bit of water, they're not vomiting, they're able to tolerate that. So if all of this is put together, maybe they don't have really bad abdominal pathology going on. They should not have something bad going on at that moment. But at the same time, you can ask them to go home. पर्सि गएर पनि अरु डाक्टरलाई क्लिनिकमा भेट्नु होला भनेर भन्नु पर्यो. तर you also have to give them return precautions. You boy भने चाहिँ ER फर्किनु भनेर भन्नु पर्यो. So again, the same things. If you're not able to tolerate PO, if you have a fever, if you're feeling like the pain is getting worse and worse, if persistent vomiting and severe pain, all of that, like any concerning example, concerning findings, you can come back to the ER. Maybe त्यति बेला चाहिँ हामीले CT scan गर्नुपर्छ होला. तर अहिले यो young person जसको pain चाहिँ control भयो medicationले, vitals reassuring, able to tolerate PO, exam findings reassuring, we don't have to get a CT scan in this person. We would get a CT scan if the pain was not controlled, or if any of these conditions, if vitals were unstable, if they're not able to tolerate PO persistently, even with antiepileptics and pain medication, or if we have peritoneal signs on exam. But with these findings, it's okay to send them home. Okay, maybe this is. So Panda is still leading and Bird is free second. Let me see if we have any other questions. Oh, we just have one last question. Oh, it says 19 of 20, but we have 2 more questions. Okay, so just arrange them in order. First, ma dekheको के हो, second ma dekheको के हो, third ma dekheको के हो. I know it's these are small pictures, but so first ma चाहिँ side ma chest ko side ma छ lesion haru, second ma पनि जस्तो flank side तिर छ lesion, third ma चाहिँ central abdomen तिर छ lesion. There are some skin findings or topical exam findings. It can be difficult because we've heard all these names, but we may not have seen the pictures for these conditions. Great, so many correct answers. So first ma dekheको side ko chest ma ko side ma भएको lesion चाहिँ herpes zoster हो. It is a dermatomal distribution. A lot of times people present with severe pain and we don't look at where it's hurting. So we have, it is important, you slide ko importance चाहिँ it is important to look at the part that's hurting. So sometimes the severe pain, flank pain may not be a kidney stone. It may be a herpes zoster infection that you didn't look at, you forgot to look at because the emergency room was so busy. So it's important to feel and also look at what's hurting. On a Gray Turner sign, Collins sign, these are both physical exam findings associated with usually acute pancreatitis, but mostly because Gray Turner sign say retroperitoneal infection, hematoma sign. You can see some sort of like ecchymosis on the flank, and Collins sign is periumbilical ecchymosis. And these are usually classical findings taught with acute pancreatitis. I know we have a lot of new participants, but let's see if some of you have already attended some of these sessions before. Okay. Some people have participated before, most people, this is the first time. All right, thank you so much, everyone. Oh, Panda the second person, the last one. Okay, good job. Bird is free. Congratulations.
Finally free.
Finally free. Okay. We will wait for questions or discussion. Let's give some time for discussion. Most of our materials, we can just talk. Because like questions up. सरी फर्स्टको 2-3 क्वेसन अलिकति अप्ठ्यारो क्वेसनहरू थियो तर त्यसले चाहिँ स्टिमुलेट गर्यो होला होपफुली है अब कस्तो गाह्रो जस्तो लाग्यो होला थोरै टाइम मात्रै त्यो क्वेसनहरूको लागि म नेक्स्ट सेसन्सहरूमा चाहिँ त्यो क्वेसनहरूलाई अलिकति त्यस्तो गाह्रो क्वेसनलाई अलि धेरै टाइम राख्ने गरी बनाउँछु क्विजहरू अनि मैले मेरो अप्रोच भनेको चाहिँ मलाई चाहिँ के लाग्छ भन्दाखेरि यो सेसन्सहरूमा लेक्चर गरेर स्लाइड सोमा पढाएर चाहिँ खासै फाइदा हुन्छ जस्तो लाग्दैन किनभने हामीले सबैले बुकहरू पढि नै रहेको हुन्छौँ यो सेसन्सहरूमा चाहिँ यसरी स्टिमुलेटिङ लर्निङ खालको कुराहरू गऱ्यो भने फाइदा हुन्छ जस्तो लाग्छ अब there's just a few things I would like to talk about before finally concluding the session. मैले चाहिँ Google Classroom मा यो materialsहरू share गरिरहेको हुन्छु यो सेसन भन्दा अगाडि पनि मैले यो पोस्टमा पनि share गरेको थिएँ सायद र Google Classroom मा यो सेसनलाई relevant कुराहरू जुन सायद most of the questions were from that 3 or 4 pages that I shared त्यस्तो पढ्न पाएको भए चाहिँ यसमा आन्सर गर्न सजिलो हुन्थ्यो होला अलिकति and स्कुल लिङ्क चाहिँ त्यो पोस्टमा अट्याच गरेर पठाइदिन्छ हामी गुगल क्लासरुमको लिङ्क जसलाई जोइन गर्यो भने चाहिँ अरू लर्निङ मटेरियल्स प्रिभियस सेसन्सको मटेरियल्सहरू पनि एभाइलेबल छ त्यसमा र अर्को भनेको चाहिँ there are some free resources that all of you can use एउटा वेबसाइट छ IEM-student.org भनेर अनि अर्को चाहिँ रेडियोपिडिया सबैले युज गरेकै होला यसमा चाहिँ सिटी स्क्यान्स एक्सरेजहरूको इमेजहरू हेर्न सजिलो हुन्छ अर्को चाहिँ mdcalc.com भनेर चाहिँ स्कोरहरू जुन क्लिनिकल स्कोर क्याल्कुलेट गर्छन् फर इक्जाम्पल हार्ट स्कोर एल्भरेडो स्कोर त्यसमा इन्टर गर्यो भने त्यसले अटोमेटिकली क्याल्कुलेट गरिदिन्छ र नेक्स्ट प्लानहरू के गर्ने यसको इम्पोर्टेन्स के हो भनेर त्यसले भनिदिन्छ इट इज अ भेरी युजफुल रिसोर्स इट अल्सो हेज एन एप एभाइलेबल फर फोन्स अर्को चाहिँ एउटा MRAP भनौँ इमर्जेन्सी मेडिसिन रिभ्यू एन्ड पर्सपेक्टिभ भनौँ जस्तै फर इक्जाम्पल अप टु डेट जस्तै इमर्जेन्सी मेडिसिनको लागि एउटा ठुलो रिसोर्स छ इट इज नट एभाइलेबल फर फ्री बट I have some friends there who have been helping out with these sessions and they want to be able to help. यो यसको चाहिँ म लिंक यसमा शेयर गरिदिन्छु है च्याटमा and anyone who is interested if you fill out this form with your names and email addresses basically I will be able to make that available for you and your benefit of attending your session saying regardless of where you stood in the quiz है एक नम्बर भए पनि थर्ड भए पनि सबै जनाको लागि available छ यो रिसोर्स चाहिँ and it's a very useful resource यसमा भिडियोजहरु छ अडियोजहरु छ or also अघि मैले शेयर गरेको त्यो लर्निङ मटेरियल स्कोर पेन्डियम भनेर पुरै फुल टेक्स्ट बुक जस्तो च्याप्टरहरु पनि छ त्यसमा so you can fill in the form here and you form चाहिँ फेरि हामी मेडलाइफ मा पनि पोस्ट गर्छौं यसको लिंक र अनि we can go from there as well अनि let's just you next 20 days जस्तोमा फिल गर्यो भने अनि मैले अर्को नेक्स्ट सब्सिक्वेन्ट सेसन भन्दा अगाडि चाहिँ त्यो इमेलमा उनीहरुलाई यो साथीहरुले चाहिँ रिक्वेस्ट गर्नु भएको छ एक्सेस भनेर पठाउन सक्छौं and I think that's it. Anyone else would like to say anything? Any questions? Was it useful at all? यसरी नै गर्दा ठीक हुन्छ कि अथवा अरु बढी कुरा गर्ने लेक्चर्स त भयो भने ठीक हुन्छ कि?
All right. Before anyone goes, I'll go because I have to leave. Planning to head out. So it's nice to see this. I'm Robali Mathena. Of course, one of the Kepan Thena Varamna and Tivalama Afiligorio. But it's good. Like technology has brought people together. It's easier to learn now. Only thing I would like to add is, as our culture or what makes it, we are like too timid to answer or like to participate, right? What I would encourage you guys is like things like these educational programs, like participate and be wrong, right? Like the wrong bhara confidence build garnuko chutai हुन्छ के like अब जसले पार्टिसिपेट गरेन अघि आन्सर गर्दाखेरि that's a different thing हैन अब हामी त्यस्तो हुन्छ भन्नाले आउँछ तर पार्टिसिपेट गरिन भने जस्तो dare to be fail भने जस्तो हैन like that makes you a solid learner अनि active participation हुन्छ अर्को कुरा चाहिँ अलरेडी थाहा पाएर like पढ्नको रमाइलो चाहिँ अलिकता छुट्टै हुन्छ लाइक रेगुलरली किताब पढ्नु भन्दा चाहिँ त्यही भएर यति यस्तो कुरा जति हुन्छ लाइक पार्टिसिपेट एन्ड फेल लाइक be confidently fail one asked. Okay, yeah, I failed one asked. That hits you more, right? Like the pain hits you more than happiness, because like you'll have like so many happy moments, and some of them but like it stucks for many years, right? So even your failure hurts, but त्यो फेलियरबाट बिल्ड गर्दै गयो भने चाहिँ बेटर हुन्छ। यसको तात्पर्य चाहिँ के भन्न खोज्छ भने पार्टिसिपेट, लाइक यहाँ फेल गरेर खासै फरक पर्दैन, इफ यु डोन्ट पार्टिसिपेट यु वोन्ट गेन, लाइक फुल्ली एन्गेज भइन्न भन्ने कुरा हो हैन। र फुल्ली एन्गेज भएर त्यहाँबाट लिएको नलेज चाहिँ बिल्ड गर्नलाई बेटर हुन्छ जस्तो लाग्छ मलाई चाहिँ। त्यही भएर पेशेन्टको अगाडि गएर फेल हुनु, लाइक पेशेन्ट एक्सपायर हुनु भने द्याट्स horrible, right? That's what we don't want to do. त्यसको लागि प्रिपेयर गरेर हो। सो पढ्ने बेलामा नलेज एक्वायर गर्ने बेलामा fail as much as you want, be happy about it, right? Like that's what I tell my students and my residents. So त्यो कुरा चाहिँ जति पटक फेल भयो नि लाइक बी ह्याप्पी, तर के हुन्छ स्ट्राइक गर्छ के, जस्तै मेरो स्कोर कम आयो भने स्ट्राइक गर्छ एन्ड टेक द्याट नोसन एन्ड इम्प्रुभ गर्दै जाने हो। And one of my mentors used to say, like, medicine is like language, right? Like it takes you 10 years or maybe 15 years of your life from birth to master your language. भन्नाले नेपाली बोल्नलाई 10 वर्ष 12 वर्षपछि लाइक मजाले सबै तै पनि पुरा भोकेबुलरी आउँदैन, शब्दकोश आउँदैन हामीलाई हैन नेपाली बोल्दाखेरि भने 10 वर्ष लाग्यो नि, त्यो पनि बच्चाको अटेन्सनले, right? Our attention is like so short now as an adult, but as a kid your attention is pretty good. With that, like you take 10 years to learn a language. So medicine is basically a language, but a different kind, right? So you do it again and again and again, right? So that means there are a lot of failures. Theo, like that's my only point. Like keep participating on this. It's a excellent platform by Suvarnadai. I'm really glad. And like the more we do like this, like it gets better ultimately, I think. That's all. All right, guys, nice seeing you all. Have a good one. I'll be heading out. Suvarnadai, I'll catch you later.
No, thank you, Susil.
Right.
And कसैलाई के क्वेशनहरु सोध्नु छ भने सोध्दा हुन्छ कि केही पनि हेजिटेट गर्नु पर्दैन। म भने तिमीहरुको दाइ नै हो, अब हैन भने we can conclude this session. के भन्नु छ? हजुर।
First of all, thank you so much, Dai. It was amazing. एकदमै यो Kahoot देखि एकदमै मैले सोचेकै थिएन, मलाई लाग्यो एउटा दुईटा क्वेशन चाहिँ हजुरले यहाँ Kahoot मा गर्नुहुन्छ अनि त्यसपछि विल गो इन्टु दैट त्यो ट्रेडिसनल स्लाइड्सहरु अनि त्यसपछि एक्सप्लेन गर्नुहुन्छ, बट द होल सेसन वाज सो कम्प्याक्टली अनि एकदम रमाइलो लाग्यो मलाई चाहिँ। अन्त एउटा क्वेशन चाहिँ यो सेसनहरु चाहिँ कुड यु डु इट लाइक मोर फ्रिक्वेन्टली अथवा त्यस्तो के हजुरको कतिको छ?
अब मैले चाहिँ मन्थली गर्न भ्याउँछु हैन। अब त्यो भन्दा फ्रिक्वेन्टली गर्नलाई चाहिँ प्रिपेयर जस्तै कोड पनि प्रिपेयर गर्नुपर्छ हैन। अनि त्यसले गर्दाखेरि अब अहिले चाहिँ तत्काल चाहिँ मैले मन्थली गर्न मात्रै भ्याउँछु के। त्यसले गर्दाखेरि चाहिँ मेरो लागि रिजनेबल फ्रिक्वेन्सी हुन्छ। अब तर अब अलि बढी फुर्सद हुँदै जाँदाखेरि चाहिँ हामी अलि फ्रिक्वेन्टली पनि गर्न सक्छौं।
थ्यांक यू सो मच, that will be enough हाम्रो लागि धेरै नै हो त्यो पनि भनौं न।
थ्यांक यू सबै एकदम राम्रो पार्टिसिपेसन भयो सबैजनालाई। थ्यांक यू यसरी पार्टिसिपेट गरेकोमा। नेक्स्ट सेसन्सहरुमा अब अलिकति बढी फ्यामिलियर पनि भइन्छ होला। अनि अब क्वेशनहरु अब सुशीलले भने जस्तो क्वेशनहरु सोध्ने गरौँ, आन्सर पनि अब सकिन्छ भने अडियो अथवा भिडियो अन गरेर बोलेर त्यसरी इन्टरेक्ट गर्यो भने बढी इफेक्टिभ हुन्छ। अनि जो सबैजनाले इन्टरेक्ट अब काउटको फाइदा चाहिँ के भने सबैजनाले जस्ट पार्टिसिपेट गर्न इन्गेजिङ हुन्छ, त्यो पनि फाइदा हो अर्को भनेको चाहिँ। थ्यांक यू सबैजनाले। आई एम गेटिङ सो मेनी कमेन्ट्स। थ्यांक यू। अब म त्यो लिंक चाहिँ मैले उसमा शेयर गरेको छु मेसेन्जरमा। अनि एमर्यापको लागि भनेर उनीहरुले गर्दिन्छन् एक्सेस सजिलै। त्यो चाहिँ के रे पोस्ट गर्दिम न मेड लाइफमा। अनि त्यसपछि अनि सबैजनाले म एन्करेज त्यो गुगल क्लासरुम पनि जोइन गर्नलाई इन्करेज गर्छु, किनभने त्यसमा पोस्ट गर्न पनि सजिलो हुन्छ। अनि म त्यसको पनि लिंक फेरि पठाउँछु है। अनि त्यो भयो भने चाहिँ पछिको सेसन्सहरु लाइक प्लान गरेर उ गर्न सजिलो हुन्छ। मैले त्यसमा रिसोर्सेसहरु पोस्ट गरिराख्नलाई सजिलो हुन्छ के मलाई त्यसमा।
ट्रु, म जोइन भइसके। प्रार्थना हात उठाएको हो, लाइक समवन वान्ट्स टु से समथिङ।
ए प्रार्थना हजुर।
दाइ एउटा क्वेशन थियो, सरी लास्ट मिनेट।
हैन ठीक छ।
हजुर यो जुन हजुरले एउटा पोस्ट गरिसकेको थियो नि रिडिङ मटेरियल, आई थिंक इट वाज अबाउट रश समथिङ। अनि रस र इफास्टमा चाहिँ कुन बेटर अथवा के रसको चाहिँ थोरै इलाबोरेट गरिदिन सक्नुहुन्छ?
रस चाहिँ अब रिलेटिभली न्यू कन्सेप्ट हो हैन अब इफास्ट चाहिँ इट वाज डिजाइन फर ट्रमा चाहिँ we're only worried about कहाँ ब्लिडिङ भएको छ भन्ने लाई मात्रै हेर्न खोजेको किनभने ट्रमामा हाइपोटेन्सन भयो भने चाहिँ इट्स मोस्ट लाइकली बिकज दे आर ब्लिडिङ फ्रम समवेयर अनि त्यही भएर इफास्टमा चाहिँ के गर्छौँ भन्दाखेरि हामी राइट अप्पर क्वाड्रेन्टमा हेर्छौँ लेफ्ट अप्पर क्वाड्रेन्ट हेर्छौँ अनि त्यसपछि युजुअली सबजाइफोइड बीबाट हेर्छौँ हार्टलाई अनि त्यसपछि चाहिँ we're just looking at the लङ्समा न्युमोथोराक्स छ कि छैन भनेर हेर्छौँ अनि त्यति भयो भने चाहिँ यो डिफ्रेन्ट कजेसहरू चाहिँ रुल अल्मोस्ट अनि अर्को भनेको चाहिँ अब पेल्भिस ब्ल्याडरको अराउन्डमा अथवा चाहिँ पेल्भिक भ्यू हेर्छौँ यति ठाउँमा चाहिँ हामीले ब्लिडिङ देखेनौँ भने चाहिँ अथवा ब्लिडिङ देखिएन भने चाहिँ इट्स नट रिलायबल तर इफ वी सी ब्लिडिङ मेबी वी सुड वेट फर दिस पर्सन टु गो टु सिटी स्क्यान यो चाहिँ सिधै सर्जरीमा गएर एक्सप्लोरेटरी ल्याप्रोटोमी गर्नुपर्छ भन्ने हो कन्सेप्ट त्यो चाहिँ इफास्टको है इफास्ट is useful for trauma patient, hypotensive, and if you see positive findings on your ultrasound, which means they should just go to the OR. If ask you said the तर रस भनेको चाहिँ इट इज युजफुल फर अनडिफरेन्सिएटेड हाइपोटेन्सन भनौँ न ट्रमा भएको होइन एक्सिडेन्ट भएको होइन तर दिस पर्सन इज हाइपोटेन्सन वी डोन्ट नो अ होल लट अबाउट दिस पर्सन अब यसमा चाहिँ के गर्न खोज्यौँ भने हामीले चाहिँ किन हाइपोटेन्सन भयो त कस्तो अब आर इन सक कस्तो खालको सक हो भनौँ खासमा यो चाहिँ ऱ्यापिड अल्ट्रासाउन्ड फर सक हो र कस्तो खालको सक हो अब हार्टको अल्ट्रासाउन्ड गर्दा हार्टमा चाहिँ भनौँ न कन्ट्राक्सन्स राम्रो छैन पोर कन्ट्राक्सन्स छ भने मेबी इट इज अ कार्डियोजेनिक सक अथवा चाहिँ त्यसको वरपर फ्लुइड देख्यौँ पेरिकार्डियल फ्लुइड देख्यौँ पेरिकार्डियल ट्याम्पोनारको साइन्स देख्यौँ भनेको चाहिँ अब त्यो चाहिँ के भयो त ट्याम्पोनारले गर्दाखेरि भएको सक इट्स सर्ट अफ लाइक अ डिस्ट्रिब्युटिभ सक भयो होइन अनि त्यसपछि के अरे इन्फ्राभेनिकाबा हेऱ्यौँ इन्फ्राभेनिकाबा चाहिँ एकदमै थिन छ त्यस एकदमै अनि धेरै कोल्याप्सिबल छ भने चाहिँ मेबी इट इज हाइपोभोलेमिक सक भन्ने भयो त इन्फ्राभेनिकाबा ठिक छ र हार्टमा चाहिँ राइट हार्ट स्ट्रेन छ भने मेबी देयर सम राइट हार्ट स्ट्रेन एन्ड इट इज मोस्ट लाइकली यस्तो यस्तो एकदमै सकै हुने गयो भनेको चाहिँ एक्युट अब्स्ट्रक्सनले गर्दाखेरि पल्मोनरी भेसलको अब्स्ट्रक्सन विच इज लाइकली ड्यू टु पल्मोनरी एम्बोलिजम भनेर सोच्नु पर्यो होइन अनि त्यसपछि अरू के भने मैले एओर्टिक एनेरिजम छ कि छैन भनेर हेर्नु मिल्यो अल्ट्रासाउन्डमा एब्डोमिनल एओर्टाको अल्ट्रासाउन्डमा र एओर्टिक एनेरिजम छ भने चाहिँ त्यो रप्चर भएर भएको कि यो हाइपरटेन्सन होइन त्यसले गर्दाखेरि हेमोरेजिक सक भएको कि भनेर सोच्नु पर्यो होइन भनेपछि चाहिँ यो बेसिकली कजेस अफ सक मात्रै हेर्ने हो रस एक्जाम भनेको चाहिँ इट्स काइन्ड अफ सिमिलर अल्ट्रासाउन्ड नै गर्ने हो त्यही कुराहरू लगभग हेर्ने हो तर के फोकस राखेर हेर्ने भन्ने कुरा मात्रै हो त्यसलाई अब जे भन्नु नि अल्ट्रासाउन्डमा हेर्ने भन्ने चिजहरू एउटै सिमिलर कुराहरू हो त्यसको नाम जे पनि भयो भन्ने कुरा ट्रमाको कन्टेक्स्टमा इट इज इफास्ट hypotension, undifferentiated hypotension context it is ROS. But ROS we see look at a little bit more things than we look at in all EFAST. Clear, boy? You're welcome. यसको एकदम धेरै रिसोर्सेसहरु पनि छ वेबसाइटहरु छ त्यसमा यसो हेरे पनि बुझिहाल्नु के भन्न खोजेको रहेछ भनेर. Thank you सबैजनालाई. We can end the session.